May I request Ms Deepali Khanna, Vice President, Asia Region Office, the Rockefeller Foundation, to please come up on the dais to moderate the session for this afternoon. Dr. Aida, Karazhanova, Economics Affairs Officer, UN Economics and Social Commission for Asia and Pacific. Dr. Aida is a PhD, promotes ICT for the development of the UN Economic and Social Commission for Asia and Pacific, UNESCAP in particular, through facilitation and implementation of the Asia-Pacific Information Superhighway, APIS, Action Plan 2022 to 2026, acting as a focal point of the ICT and Disaster Risk Reduction Division of the ESCAP. To ESCAP's Sustainable Business Networks, ESBN, the Task Force on Digital Economy and the Disaster Climate. She's interested in packaging projects enabling policies and digital technologies in linking the digital green components. In the past, Dr. Aida has focused on urban water governance and inclusive development through policy and advocacy, with the special emphasis on decentralization of solutions under technical cooperation projects with the Asia-Pacific Water Forum Network, and has supported Asia-Pacific Water Summits. Thank you, Dr. Aida, for being here with us this afternoon. The privilege of finding a sister soul across continents, Ms. Alois Todd, co-founder of the Pandemic Action Network, Brussels. Alois is an advocate of policy, campaigns, and strategy specialist with over 20 years of experience. She works towards bringing change in policies, legislations, and budgets to improve lives. Primarily, she has worked in the international development and global health, including as a political advisor with the EU institutions and as a global policy director of the One campaign. Alois co-founded the Pandemic Action Network with 3 colleagues in April 2020 and took the executive director's role in August of 2022. The network fights to prevent future outbreaks becoming pandemics and to work for equity in all areas of pandemic prevention, preparedness, and response. Thank you, Alois, for joining us. Again, I have Professor Mushtaq Chowdhury, advised James P. Grant School of Public Health, BRAC, University of Bangladesh. And since I have already introduced him, I would just like him to join the forum. We have Dr. Jeremy Lim. He is going to be our online participant, Associate Professor and Director, Leadership Institute for Global Health Transformation, the NUS CSO Hawke School of Public Health, Singapore. Dr. Lim is the co-founder and CEO of AMILI, the first dedicated gut microbe full-service company in South Asia. A director of the Leadership Institute for Global Health Transformation, LIGHT, at the NUS Swi Hawke School of Public Health, where he works to enhance the cooperation, capacity building, and knowledge sharing across the region. Trained in surgery and public health, Dr. Lim attained various postgraduate qualifications, including the membership in the Royal College of Surgeons, Edinburgh, Masters of Medicine, NUS, and Masters in Public Health. Johns Hopkins is a Fulbright Scholarship awardee. What a privilege, Dr. Lim, to have you here with your special interest in ways that technology can increase health equity and access to healthcare. I have another of our TAG members, an illustrious person, Professor Shalini Bharat, Director, Vice Chancellor for the Tata Institute of Social Sciences in Mumbai. And we do have a lot of our workforce as alumni from the Tata Institute of Social Sciences. Professor Bharat has nearly 4 decades of experience in teaching, research, capacity building, advocacy, and the field of action in broad areas of social science and health, social development, family studies, and minority community demographics. Known for her work on equity and access issues with special reference to reproductive and women's health, social determinants of HIV and TB, including stigma, discrimination, and human rights issues. Multi-purpose prevention technologies for the HIV epidemic, self-testing for the prevention of HIV, young people's health and well-being, family studies and child adoption, women, work, and family. With her wide experience in community-based research using qualitative and quantitative and mixed methodology research approaches, she has contributed to deeper and more nuanced understanding of the social and gender dimensions of a range of issues concerning health development and well-being. I request Dr. Krishna Reddy Nallamalla to come and please set the context for the session, and then for Deepali to please take it forward from there. Thank you so much.
Yeah, thanks, Uma. I think just a brief context for this session. As you noticed, the first session was to actually lay the foundation of the overall health systems and discuss how we assess those health systems in the context of different building blocks or different functions or the different elements. So this session actually starts with the people as the center of the health systems. Because most of the time we talk resilience in the context of the health system which is responding to the people. We don't talk in terms of the vulnerability assessment of people against which the health systems are supposed to be resilient to address the vulnerability of the people, both during the normal times as well as during the crisis times. Similarly, the health status of population, we only look at again from the function of health systems, but we don't look the health status of population in the context of the social determinants, the economic determinants, the commercial determinants, the environmental determinants. As a part of assessment system in terms of the health status assessment, I think there is a need to do this assessment along with other determinants, not just the health system as a determinant. The other thing is what role people can play in the resilience. One, they can take care of themselves. Two, they can have the basic understanding of infection prevention and control. Three, they can participate in the governance. If they have the enough health literacy, they're empowered to ask and participate the other two key players, the private sector and the public sector, as to their accountability. The lack of literacy is the information gap which makes them disempowered to participate in the governance. And within this sector, I think the other element is the equity and the inclusivity issue that is becoming, because most of the time we look at population as a whole without looking at these defined populations which are more vulnerable, whether it's based on gender or whether it's rural, based on religion or race or economic condition. So these are the issues I think the panelists represents the society, most of the panel member, either from science and research perspective, like the Tata Institute of Social Sciences, or people representation as an activism, as a pandemic action network, and the BROC, which is a civil society organization which acts very closely with that. And we have academicians and others. I think this is the apt panel to discuss this thematic subject, because this leads to the theme carrying forward into the future as well. It is not the end of the journey of this theme. It's the beginning of the thematic journey. Then we should crystallize what is the actionable points in terms of population literacy, health literacy, digital literacy, because they are causing the determinants, they're becoming the determinants, and how they participate. I mean, we always say people have to participate, but how do they participate? What are the case examples of participation? So these are, I think, some of the practical issues related to the people as the center of the health systems. Over to you, Deepali.
Yeah, thank you, Dr. Reddy, and good afternoon, everybody. I hope all of you had a great lunch, and before that, I think the sessions have really been invigorating, and based on the feedback that one is getting, it's not just about getting new insights, but also getting inputs in terms of how the collaborative can be much further strengthened, and I think that's really something that we'd really like to get more and more ideas, because that will be really important for the HI team and us going forward. So as mentioned by Dr. Reddy, there are many determinants of health that should be considered when improving the resilience of health systems. We saw many of these play with the pandemic, the impact of the human activity on the environment, and exposure to new pathogens, national capacity to harness resources in support of these health responses, such as community health volunteers, economic disparities, social disruptors, like social media, even geopolitical factors. So that's quite a gamut. At the foundation, our health programming has evolved since the early days of the pandemic, when we supported health systems to quickly and equitably be supporting access to affordable testing. We also supported increased pandemic surveillance capacity through a Pandemic Prevention Institute, as well as vaccine equity through our Global Vaccine Initiative. And I'm very glad that Angela is somewhere here. Angela, you want to raise your hand? There you are. And of course, we have also, we were talking about partners in crime. Abhinav is also there, who was a partner in crime in terms of making all that happen. An underlying goal for all these programs is to strengthen national health systems' ability to rapidly detect emerging threats and eliminate barriers to vaccination among marginalized communities. Looking to future determinants of public health, the Foundation is examining actions at the intersection of climate and health. As climate change is unfolding before our eyes, it is causing numerous direct and indirect impacts which directly influence how we think about future health systems, design, focus, and most importantly, resilience. Whether it is expanding infectious disease zones, heat-aggravated NCDs, or ensuring climate migrants have continuous access to quality healthcare, climate change will be impacting healthcare systems for decades to come. Again, I was mentioning earlier this morning, I was in Bangladesh, and it was really quite daunting to hear that, in Asia alone, by 2050, we're going to have 50 million climate migrants, and 20 million of them will be in Bangladesh. And as it is, if you're seeing how Dhaka city is choking, Mushtaq Bhai, there's a lot that needs to be done. So I'm really looking forward to kind of carrying forward that conversation later. And as I was saying, the climate change piece, this is just one set of determinants we need to consider, which in turn influence the kind of strategies we need to enhance resilience. Looking at national level, we must consider social, economic, commercial, and environmental determinants, determine which present the greater risk and what actions we can actually take to address these risks. Going back to what you said, Dr. Reddy, this morning, it's all about knowledge to action. And I think action is going to be really something which is going to be really important for us. Our very meeting here today with other actors from across sectors underscores the importance of social actors to sustain focus on health resilience and help overcome barriers in reaching it. This afternoon's panel will explore these themes and others mentioned by Dr. Reddy in his comments. I'll start with a few questions to the panelists, which I'm sure will raise further questions from the audience that we can take later on in this session. My first question, of course, is going to be to Jeremy. So Jeremy, thank you so much for joining us.
No, not at all.
The question that I have for you is, are there assessment frameworks that include various determinants of human health? And do governments really use these in evolving their policies?
Yeah, and firstly, thank you very much for the invitation, and I apologize I cannot be there in person. I actually got back to Singapore only this morning, So it was, and I spoke at the Wharton Global Forum in the morning before coming here. So my apologies that I'm not physically present. On your question around the indices, thankfully there are many. Right? For example, the UNDP has got the Human Development Index that looks at a long and healthy life, looks at education, or more broadly, the dimension is described as knowledge. And finally, the third dimension in this is around a standard of living, right? So the science of measurement and putting them together into composite indicators is not new. It is pretty mature. But the use case, I am sad to say, has been disappointing. Typically, it's a group of us as academics, as social activists who talk about these amongst ourselves. Maybe there is a flash in the pan reference in one of the newspapers that's really about it, right? And as I reflect on the use or the misuse of matrices and indicators more broadly, if you look at the corruption index, if you look at ease of doing business scoring by the World Bank, these are much more seriously taken by governments because they affect the economy. And perhaps the broader question for us is, if a 3-year plus pandemic has not taught us the importance of health and health for everyone, what will, right? And maybe are we as a health community smart enough to put together the indicators into indices that policymakers will pay attention to? And perhaps the closest one that I can find in the health space is the Access to Medicines Index, right? Which policymakers don't look at. I will be pretty brutal and candid, but because the Access to Medicines Foundation has been pretty effective in engaging with investors, pension funds, large funds, and say, oh, you should invest in this company because it ranks high on the Access to Medicines Index. This one you should downgrade. When it hurts companies in their pockets, that's when people sit up to pay attention. And I regret that when it comes to universal health coverage and other indicators that matter to the bottom of the pyramid, that matter to equity, we have not been as good as we need to be. And I'll pause here and back to you. Thank you very much for the time to make these comments.
Thank you so much, Jeremy. Thank you so much, Jeremy. I just have an additional question, and again, I'm not a health expert, but I'll still pose this. So recently, we've been talking to the IPCC team, and every year they release their report. And I think one of the feedback that one has received is that the tools and the assessments that they're using are very north-centered. So, in terms of really keeping the reality of the global south and the tools and the data that we have is quite different. I was talking to somebody who actually is doing some very interesting work in climate modeling at IIT Delhi and said that, because the tools and the methodology are so alien in terms of what is being used in India, and hence the results that emerge from some of these reports are not really, the policymakers are really not able to take that on board. So my question to you was, Jeremy, are you seeing something like that also in the assessments on the health side? Are they also all driven from the north? Or, you have assessments where the global south is very actively involved, and hence, there's more ownership and policymakers are taking those things on board?
And I'm afraid I cannot see the audience that is in the room, and I apologize in advance if I offend anyone. But I'm afraid that for many of us in the global south, and Singapore's a bit neither here nor there, but we seem to be embarrassed to assume intellectual leadership, right? And when I say we, I don't mean we as academics, we as practitioners, but more broadly, it's somehow something that comes from the global north just seems more credible. Many of our own governments will look at our own citizens and say, wow, it's so good, it couldn't possibly have come from one of you, right? So unfortunately, we haven't, and I'm going to use a and I'll deliberately use a rather inflammatory term, have we colonized ourselves, right? And not given ourselves the opportunity to unleash our fullest potential, including our intellectual potential. But as it stands, really, I'm not aware of any widespread set of indicators that have come out of the global south that have been accepted universally.
Thank you, Jeremy, and thank you for your candid response. I think going back to the Global Learning Collaborative, there's a lot for them to be thinking about. Of course, it's a Global South-led initiative, and I think just in terms of the people who are behind it, I'm sure you can come out with assessment tools that are really fit for purpose and can make everybody proud. So thank you. I'll now turn over to Mushtaq Bhai. So Mushtaq Bhai, general literacy is an important social determinant of health, as we all know. There's a growing recognition of the critical role of health and digital literacy in people's health. Is there a case to focus on these two critical determinants, or are we missing, is there something more that we need to be adding?
Yes to both. But to me, literacy, whether it is general literacy or health literacy or digital or the financial literacy, which is also becoming very popular, these are all sources of empowerment. This morning I was talking about ORT, knowledge transfer. So that's also a kind of a literacy. But if we stop there, just providing the information, then it becomes very passive. And this takes us to the point where the Brazilian philosopher Paulo Freire talked about in his Pedagogy of the Oppressed. And what he said is that if we really restrict ourselves to just literacy or just the passive literacy, then we are not doing our job. So the literacy has to be very critical literacy, that people must act on the literacy, so that I mean it really sort of brings change in the way the society is moving. So that's one thing. The other thing is of course the question of I mean what else it should include. And to me, it's not only the information about what the disease or their solutions, but also making the community aware of their rights, so that they demand services and also take active role in the implementation and also monitoring of the health system. So I feel that literacy has to be there, but it has to be very critical literacy, so that people can work and then get something out of that.
Thank you so much, and you raise a very important point about demand. I would also add on to say accountability, because at the end of the day, how can our communities really hold the people who are supposed to be delivering on those services accountable for the quality of services? And the more they're literate, the better they're able to really demand and also really ensure whatever is needed in their communities is actually getting there in the right way possible. Shaldi, I'll ask you the same question, because I think you've been doing so much of work around it. And also, again, health and digital literacy, there's such phenomenal examples coming out from India. I'd really want to get your kind of perspective as well.
So thank you, Deepali, for that. And let me also thank Access Health International and GLC for giving me this opportunity. It's a great dialogue that we are actually having, and much needed post-COVID. So let me do a little step back and do a little bit of a broad basing of this whole topic of health literacy or digital literacy, and now we are talking about health literacy as one of the determinants. but in the morning we heard Dr. Sohail and we also heard Dr. Kwam talk about, raise this question of the so-called, developed economies and health systems, very strong health systems, also failed in the face of, COVID. And that there is a need for, going beyond the biomedic and so on. And I think we were only looking at, solutions within the hospitals and so on, and we know what all happened. Now, but are we surprised? I'm not, really. Because I think, we haven't really, although we talk about social determinants and so on, but we are not unpacking the vulnerability concept, better than what we should be doing. Because if you try and see why and how do people become vulnerable, it's not just because there are no health systems or there is no hospital or there is no treatment, medicine available, but they become, vulnerable because they engage in or they do things or even desire for things which probably place them at the center of some kind of difficulties over which they have no control. And those systems are outside, but certain characteristics of their own or the situations in which they are, they make them, very vulnerable. And we talk about several things. For example, we talk about, and we are only sometimes talking about demographies, young people are vulnerable or women are vulnerable or, older people are vulnerable. But if you look beyond that, you will find that, we need to talk much more about things like social norms, gender, poverty. We need to talk about the situations in which people sometimes are. For example, they are mobile, they are migrants, they are refugees. They are also vulnerable because of their, gender identities, because of, their disabilities of some kind or the other. But when we talk about vulnerability, we are not talking about all that, So we really need to go more granular. We need to talk about that. And that is the true meaning of social drivers and social determinants. So while we have these, the concept of social determinants, and we are, sort of owing a lot of allegiance, I would say, to this whole concept, and making it possible for governments and policies to incorporate this. But in true manner, this is not happening. And I don't have to go very far. First of all, so how do we do it? If we do vulnerability mapping or assessment, we'll realize that there are many more layers that we have to remove before we come to this, this concept of vulnerability. And I don't have to go very far. COVID, of course, was one very glaring and very recent example, but many of us who have worked in the field of HIV, we know why, the world over, wherever we made a difference, I think it was because of, understanding what is driving this epidemic. It is not just that virus or that one, some disease element, which is, it is the poverty, it is gender, unequal gender relationships, inequalities, income inequalities, all that was. And in countries where this was addressed, you could see that, at least it was slowed down. And India is the very good example, and we have Samiran Panda here, we worked for many years in the HIV epidemic field. We realized that, trying to, address these issues slowed down, and also investing in communities and people slowed down. Now, if I contrast this with what happened in the TB, disease, because I've recently worked somewhere in that also, we realized that in that nothing of this sort was ever considered. We never thought that there were gender dimensions in TB. We never thought there was stigma around TB, which is a big roadblock. But we didn't address that. We never thought that counseling would make a difference. We never thought that, investing and bringing peer, communicators or peer, bringing the community into this whole thing. And now we are able to do this and are seeing some difference. So I think, so now to, answer your question about the health literacy, I definitely think that health literacy is so key because there is a lot of health information asymmetry in our society. And only through, having the kind of empowerment that we can have through health education, through health literacy, and now because there are so many digital platforms, we need to be also talking about digital health literacy. So definitely these are very important empowering instruments and tools, I would say, and I think we all should invest in that. But I'll stop here for a moment and then carry on for the rest of it.
Thank you so much, and you make such good points around the kind of things that need to be done, the vulnerability assessments, the kind of learnings that you've had, and how does the wider network not reinvent the wheel and go through the same learning curve, again coming back to the need for this collaborative that we're talking about. I think also as a funder, we struggle because I think at our end we don't necessarily harmonize and really see what kind of research is being done by different foundations, and literally we'll end up probably doing similar things, whereas what is really the need of the hour is to kind of take the research that exists maybe to the next level. So again, I think just in terms of the Global Learning Collaborative, Uma, I'm looking at you, in terms of the whole research agenda, where does it fit in? How do you also kind of just create that inventory of what's out there, and how do you make that available? Because I think everybody is so busy also, it's not a fact that people don't want to share. And also, I think in this community, people are willing to share what worked, what didn't work, but they don't know where and how that can be done. So I think definitely the Global Learning Collaborative will provide that opportunity and is already doing some work in that space. I guess, Eloise, turning over to you, and thank you so much for traveling for so far to be here with us. We've learned a lot from the pandemic that public health issues become deeply political at international, national, and local levels. Elected representatives have a challenging role in this situation, needing to address public needs in the face of a complex and often misleading information space, and sometimes low public trust in government and public health institutions. Trust in leadership and public participation in public health have been identified as crucial in how health systems respond to pandemics, or they don't. What more can we do to strengthen both of these in preparation for future health shocks?
Thank you so much, and thank you for the invitation to be here. It's a real privilege to be with you all. So there are so many ways to answer this question. One of the biggest experiences we had at the Pandemic Action Network in the last few years was obviously the big misinformation around COVID-19, vaccines in particular, but not only limited to that, skepticism about COVID itself. And we started a behavior change working group where we would have a collaborative space for experts to come and bring their findings and hopefully learn from each other. And I think that this is why this Global Learning Collaborative is so brilliant. It's about how we learn from each other, but how we turn that learning into action, as Dr. Reddy said earlier. But over the years, some of the things that we learned, if we're talking about actionable insights, which I know is a big priority for our 2 days, of course the social, cultural, political, religious backgrounds of people are hugely important. And the biggest learning point, which has already been mentioned, I think, is that community leaders and getting the right people on board, the right messengers, whether it's in a crisis time like COVID-19, but also to get people involved in health systems. And I think we have to, a lot of things went wrong during COVID, but also some systems were set up, some interfaces came together that have now dispersed following the crisis. And we actually have to do a better job to see how we can keep that connectivity, that intersectionality going on in between crisis times. We heard all sorts of different things. We pulled together communities from Myanmar, First Nation communities in North America, from Bangladesh, from Kenya, from Rwanda, from all over the world, from Egypt. And we heard that there were huge issues in First Nation communities in North America because they had a legacy of being guinea pigs tested upon by others, and so they had that pushback to anything at all that came from outside. Similar feelings also sometimes in African countries, and let's not forget, this is not just rumours started in communities that we were trying to fight. We had the French president go on TV and say he thought that the AstraZeneca vaccine was quasi ineffective, half ineffective. And so possibly an outpouring of Brexit, a bit of a kick to the British-made vaccine. But things like that had a huge impact on skepticism within Europe, but also overseas as well. So just to say that while we think about the community piece of this and understanding how we bring people together, work in a networked way, which is at the heart of what we do at Pandemic Action Network, we have to be able to get out of the health silo. We have to be able to take all this knowledge and expertise in this room and translate it and make it easy for others that want to be helpful but don't have the expertise to engage. But we also have to do that job with policymakers and politicians, make sure they're saying the right messages, and for sure making sure that they don't say the wrong things and fuel misinformation. There are many other examples. I didn't mean to pick on President Macron. I'm a proud European. But just to conclude for this section, putting people at the center of this also has logistical elements. There are, of course, we have to be able to translate messages and get people into healthcare centers, but there are also ways that we can organize things that are within our control that we can use. We found in studies, for example, that healthcare systems and providers that made it really, really easy for mothers to take kids after school or get vaccinated themselves, put it in their way, put it adjacent to schools, make it easy for people to take the action that you want them to take. It's such a simple premise, but then vaccination rates or healthcare interventions and interactions go up. So there are things we can control, and it's that social proofing, community leaders, religious leaders, making sure we have the places for that interaction. Where do we have those places to talk to those leaders? Where is the communities in this room today? If you're thinking about talking with religious leaders, politicians, policymakers, where and when does that happen? And if it doesn't happen enough, how can we create those spaces? What's the networked version of this conversation that brings those people together? What's the political leadership version of that that actually institutionalizes this? One of the thoughts that I've had about the COVID crisis is, we are struggling to make the case on pandemic prevention and preparedness because it's dropped off the political agenda. We almost need a constant version of whatever your country had as a National Security Council, COBRA in the UK, special committee like they had in Belgium where I live. Where that disbands after the crisis era is over, but we need an ongoing piece of that so that we have the employment, the education, the health, the whole of government, the whole of society approach that we talk about, but really only came into action properly during that crisis time. So let's organize for that around times of non-crisis, and I think we'll do a much better job of serving children, women, intersectional differences across the board in between crisis times. I'll leave it there for now. Thank you so much.
Thank you so much. And as I said in the morning as well, what is really worrying is that we all knew before the pandemic that we weren't prepared. And now with the pandemic, I am not even sure whether I should say it's over. It's not. But we still kind of have to, again, remind people of the havoc it's caused and how important it is for us to really strengthen our health systems. If I had to give you a magical wand and say, what are the 3 things that really would get people and our global leadership to really act in a way that is the need of the hour, what would be the 3 things that you would say?
Well, that is the billions of dollar question. What we are currently trying to wave with our magic wand right now is that, of course, there are the lives saved. Of course, there's the health imperative, but there's also the economic cost of inaction, the relatively small inputs that we heard in our opening speeches this morning. Unfortunately, these logical arguments, whether it's about boosting bioeconomy, saving money long term, relatively small investment, the human impact of saving lives, the human impact of not going through COVID, again, all of the mental health issues, the lack of learning, the human development costs. I'll tell you, it's a psychological and difficult issue because all of these pieces should lead leaders and the general public to think, sign me up, I will give some money, I don't want this to happen again. But I think we're experiencing a psychological phenomenon where people don't want to engage with it because they want to believe it's over. So I don't think we've cracked it. But we have to keep making those arguments nonetheless. We have to keep talking about the relative cost of inaction. But I do think that one of the biggest things that I would do with waving my magic wand is organizing to have a permanent sort of, we talk about having a global health threats council at the international level, but we need an equivalent really at the national levels or subnational levels where we have a place for this agenda point to not be dropped and for that intersectionality and cross-government, cross-society approach to be made. So, and I would also gather leaders in a room and give them the equivalent of the sort of, the TED talk from of all time to say, here's 20 minutes on what happens if, a new pathogen. Imagine if H5N1 was human to human. Here's what we could be looking at. Here's why you need to act. So those are a few things that I would do and we are trying to do, but we need to work together because it's really hard at the moment.
Thank you so much. Swadika, Aida, we both live in Bangkok, so I am taking the liberty of welcoming you in the Thai language. You represent UNESCAP, that is engaged in economic and social development in Asia Pacific. How do you see UNESCAP's role in addressing the social and economic determinants of health in the post-COVID era?
Oh, thank you very much. Sawadee-ka, colleagues in Kazakh is Rahmet. Assalamu alaikum. I work for Economic and Social Commission for Asia and the Pacific. Quite proud of it. Last year we celebrated 75th anniversary. It's a decision-making body. It's like international parliament in Asia Pacific, which is consisting of 53 member states and 9 associate members. And we are one of the 5 regional commissions and the biggest commission. So we are very humble and also trying to work very impactfully, support with knowledge products, platforms, and different frameworks. With regard to your question on pandemic, our commission and secretariat is consisting of 8 different thematic areas. They're all cross-cutting. So when the pandemic hit, our divisions worked hard on organizing themselves, looking at the different aspects of macroeconomic impact, social vulnerabilities. We looked at the environment and health aspect and nexus of the issues. And I work in ICT and Disaster Risk Reduction Division of ESCAP. So for us, it was extremely important to look at the information systems. We looked at disaster preparedness and response, and we also looked at quality of data. So you could check our reports. We didn't have much time to report to wider audience, but you could see in our website good reports looking at the different decreasing trends, ecosystem degradation and issues of climate change. We also looked at the aspects of digital divide. So the digital divide and the different vulnerability groups are mostly exposed to the COVID, and now post-COVID data is giving a lot of perspectives for collaboration. So in this regard, thank you very much, Deepali, for your question. I would like to highlight 3 reports. One report is prepared by Environment and Development Division, which is connecting connecting two sectors, environment and health. And the vision is working very closely with WHO. So One Health is the main outcome of that report, and trying to stimulate and motivate ministers at the highest level to collaborate, like organize their wedding, right, with the different programs. And then the other interesting work that is also born in our division, our sector, is disaster risk reduction portal. So where you can look at hotspots and look at disaster, environment, health nexus issues. From my table, I also would like to highlight the work of my colleagues and my own work on digital transformation report. We have just launched it last year, and we just had a big ministerial conference, the ministers level in Seoul. Seoul hosted in November, where we launched the report, and also e-resilience framework. So I was very happy and very humbled and proud that Global Learning Collaborative was interested in the methodology. We looked at 5 dimensions of e-resilience, where the interconnectedness would never allow any sustainable change to happen, because if we don't have policy, you will have resistance. If you don't have infrastructure, you have rigidity. If you don't have data, you have anxiety, right? So all kinds of issues will happen to actually magnify the unsustainable patterns of the existing era. So the transformation and the way out of that, that's what we are offering as a flagship reports for ministers and decision makers. And we try to visualize them because it's difficult, complex aspects. So for example, we visualized internet speed, and we know that with COVID, internet bandwidth expanded. We know that internet traffic expanded. At the same time, GDP dropped, digital economy raised, so vulnerabilities, yarning, right, with a big gap. So how to deal with that? So my job is to pick up the tools, learn from your wisdom, try to bring the mechanisms of connectivity and system thinking. So from ICT, we know that there are a lot of systems, and how to deal with that systems. What is the leverage point of multiple impacts? And today we discussed a lot of assessment tools. So we also bring them like from rapid perspective, from strategic perspective, from environment perspective, so now health perspective. So thank you very much. It's an amazing session and a good discussion.
Thank you so much. And I must say that I've learned so much about you around these 3 reports. I just want to turn to the audience and say, were any of you aware of these 3 reports that Aida just told us? Anybody? No. I mean, that's really the challenge for us. There's such good work happening around Asia. I don't even have to go to a global level. How do we just kind of, and Dr. Reddy, I'm looking at you. How many people saw the Access Health International reports? I think, there's such good work that's happening that can really help advance the work that each one of us is trying to do. How can we, and I'm speaking on behalf of you, Dr. Reddy, at least the Global Learning Collaborative can really make a beginning in terms of just collecting all these rich reports, insights that are available out there, and making sure that all the right actors get it, because I think that really will be important. I know Sandhya, you're still here. Sandhya from CSEP. No, she's probably left. Okay, because we were in conversations, I was with her, with the CSEP team, where we were again looking at India in Asia, deeper engagement, where, we're also trying to understand, like, if I look at Africa, and I know I shouldn't be making comparisons, but you do have an Africa CDC where at least there's an attempt for different parts within the health system to at least kind of have a go-to place. I guess in Asia you have ASEAN, which is leading some parts of this. I'm not sure around SAARC what I can say. I know there's also been an attempt under the ASEAN leadership to create that ASEAN Center for Public Health and Emergencies, but that in itself has become so political, and there are 3 countries where that's going to be hosted. So in that backdrop, I think there's so much that this collaborative can really take on as a very important role. where there's phenomenal work which is happening, and how do we really make sure that the ecosystem benefits from it, policymakers also benefit, and where there are gaps, how can we kind of tap into the resources which exist within the members of the network? 17 countries is not a small feat, and I'm sure it's only going to grow, so there's a lot of potential. But coming back to you, Aida, I just have a follow-up question, which is really around leadership and coordination, the role that you can play, because obviously I have a lot of respect for you and SCAP, but how can you really help so that the national ministries, UN agencies, and the public really can be better informed? I know within the UN system also there's that harmonization where there's the UN resident coordinator, but there's so much more that needs to be done. So any advice, any thoughts that you'd like to share with us around the coordination function?
Thank you very much, Dr. Deepali. Colleagues, all of us know that knowledge is instant, right? So this is an amazing opportunity. It's sad that it's only annual, it's once a year, where we instantly share the knowledge that is coming from our hearts, and we're connecting through our minds. So I think this is one of the things that we need to take to the next level, right? From my side, I will try to report to my office and inform them on their need to work with health systems and maybe organize the digital and health wedding. So sorry about that. But in more of intersectoral collaboration and nexus, where the multiple ministries and disciplines can actually manifest the joint joy of sharing the wisdom into actionable products. So from ICT, we work with digital ministries, and we try to inspire them. This year there will be commission session resolution, and Mongolian government brought a resolution on Asia-Pacific Information Superhighway Action Plan, where there are 3 pathways. One is on infrastructure, where the connectivity e-resilience coming in. So how do we know it's implemented? These projects should come up, right? Second, digital technology. So we talk about GovTech, FinTech, Health Tech, EdTech. So all of these, if ministries of digital development enable through policy frameworks at the regional level, maybe we can fast track the tech application. And data which is most difficult. At the same time, tech products can make them interoperable and meaningful, where the instant knowledge from technical perspective would become more valuable. Thank you.
Thank you so much, and I like that reference to the wedding. As long as we're not going into forced marriages, I'm fine with it. Which some of us try and do, and they never work out.
Arranged?
Arrange also, maybe. Okay, we can have an offline conversation around that. Otherwise, I'll turn to you again. And I think you did touch on some of this, but how do you really see political, cultural, and religious systems influence people's health? And unlike the other determinants, these are really difficult to modify because they're so deep-rooted, right? In some cases, they're just part of our DNA. And then how do we need to factor in these while comparing health systems? So I know it's quite a lot that I'm asking of you, but I know you can answer it. So.
Well, that's kind. Let's see how we go. I mean, I did touch on some of this a little bit earlier, and I think from everything we've learned from the misinformation campaigns that we've seen, whether it was in Nigeria in 2003, whether it was the difficulty we saw last year in Uganda around Ebola, and the sort of suppression of the seriousness of the situation. That was the sort of messaging from political leadership that I already spoke about is hugely important. But there's also important things that it highlights within the system, especially like the gender inequity in terms of people looking after the sick, or the majority of healthcare workers being women in a lot of countries and a lot of places. And things that happen during lockdown, such as if you don't have as many women decision-making, then you also, in many countries, sexual and reproductive health rights went on the back burner access to essential services was not provided for through those lockdown periods. So you have that kind of knock-on effect from not having the right people in the room. So what do we do about that? How do we mitigate these kind of deep-seated cultural norms? We have to get community leaders on board, and that's not just add instant hot water at the right time. This is a slow burn, hard yards conversation that needs more investment in the human side of things. So whether it's more community healthcare workers, whether it's constant data collection, but also that feedback loop that we mentioned earlier, knowledge to action, action to knowledge. It's not just a one-off snapshot. It's understanding, well, if we tried this during COVID, for example, and it didn't work, why did it not work, and how can we tweak and improve? And so the investment side of it, of course, we all want more investments in healthcare systems generally, but also in this, how we roll things out successfully, how do we successfully communicate? I'm sure people with very strapped resources don't want to be investing big money in communications, but we need to be pushing governments, employers, all sorts of people to be having conversations and investing in these kind of communications pieces, because until and unless we have ongoing communications around health issues and health services, then we won't be able to get to people at the time where we might really need them to urgently, or to have integration in the health system, so we have that preventative element. So I think things like social listening that were really important during the COVID crisis are things that we could continue with and going on. And there's some amazing studies done by colleagues of ours at Internews that work in about 18 countries around the world. And they have a bunch of really actionable recommendations on social listening and how to constantly have that feedback loop of information and what we can learn from it. And so I think there are, when we think about how to organize ourselves and how to organize taking action, for me, this is one of the hardest bits of this conversation and this conclave, because we often, not always, and they're always changing, but we often have the answers, the ideas, the things we want to action. But what we don't have is the constant rhythm of turning words into action and the place and the people to do that and to report back. And I would say, from a very humble, one tiny perspective, from the Pandemic Action Network perspective, we would love everybody in this room to join. We are the only thing you have to agree is that you want to prevent future pandemics. So it's a low bar, but I would say high quality members. You can look on our website. But basically, we try to convene online, so we still work a little bit like it's lockdown, even though it's not. But that allows us to work globally, and we try to be something of an interface between community groups and political leaders. And just as other colleagues were talking, I just wanted to put some ideas out there on things we can do in terms of that where do we start element. And I think that finding best practices is always an essential part, which is, everybody in this room has a role to play. What's worked, where and why, and how can others learn from it? Of course, these things are context specific, but it's very inspiring to learn lessons from best practices. And then we need to find our champions. And I think, as well as an advocate and campaigner, we often get locked in the idea of countries. But what about cities and sub-regions and exciting leaders that actually want to do things a bit differently? You can often do things in a much more innovative way at a city or municipal level. So maybe we can think about how to form our best practice approach in this kind of whole of government, whole of society, health system strengthening, and find some champions in all sorts of different places around the world, and then go from there. So I think we also have to think about what are the routes to change, to get our words into action. So I've veered a little bit off course there, but since I semi-answered it in the first question, I hope you'll forgive me.
Yeah, thank you so much. You did. I think a couple of thoughts. One of the things I strongly believe is that you also learn from failure. So it's not just about sharing best practices, but also what hasn't worked, because there's big learning so that others don't have to go and learn themselves with something that you've tried out and hasn't worked. And I think the community that Dr. Reddy is trying to set up will have that maturity that, you're not being condoned if you're talking about things that haven't worked. So I'd really encourage that to happen. I think also you brought up at a very interesting point around the Pandemic Action Network. You have the, what is it called, the JLN, the Joint Learning Network, as well, that Mushtaq and many others, who've been associated with GLC are also part of. So various networks out there as well. And obviously there's no competition between these networks. There's just so much work that needs to be done. But can we converge on a few actions that, as we're pursuing our own networks, but there's an overarching two things that all networks are definitely going to be, converging on and really trying to push the needle, because that's really the need of the hour. The more our policymakers, the ecosystem actors, really hear those messaging and the actions that they need to take, will give more solid voice, and the chances of it kind of being heard are much higher. So I think that's something to think about. The other piece is that, we all heard at the G20 leadership, the Indonesia side of the G20, the Pandemic Prevention Fund that was launched, how we're making sure that folks in this room are sharing what is being learned, what really needs to be done, is also an important issue, because we can say, well, this needs to be done, but then there could be not this network, but the other networks that are intersectioning with what's being done through the Pandemic Prevention Fund. We have a wonderful opportunity in India this year, with India's leadership, and I know there's a health working group. Are there 2 or 3 important points of actions we really want the policy folks, the leadership to be really pursuing, or what are they kind of thinking about, and how can the Global Learning Collaborative, by virtue of all its members, really be bringing back, and a lot of your members are also from the G20 countries. So how do we really reinforce some of those messages? I think we can keep complaining or saying, hey, we are not being heard, but there are those opportunities that do exist. G7 for the first time is happening in Japan as well. Now there again, if health is not discussed, pandemic is not discussed, then that's just too bad. So I think, and of course the last piece is that for the first time, I want to call it an Asian COP, because that's what the president of COP28 said, even though it's happening in UAE. For the first time, there's a health track in a COP28 conversation. So how are we, through this network, other networks, really kind of being strategic and saying, hey, these are the 2 things we really want to make sure comes out from COP, because in the past, there hasn't been a health pillar at all. So that's just something to think about. But coming back, I think what I will do is I'll pose a question, and Mushtaq or Shalini, both of you feel free to pick up any elements of that, and then we'll open it up to the audience, because I'm sure you have tons of questions. It's rare to get such a good set of panelists here. And so my question to Mushtaq and Shalini is, community health volunteers have really become a critical bridge between communities and health systems. Social organizations that are deeply embedded in societies and are trusted play a similar role. However, governments are not always able to unlock their potential for impact. How can governments better structure, nurture, and enable community health volunteers? What policy is best set up for success, and what trust-building measures are needed? I think my heart really reads when I see an Anganwadi worker. Every time, I think for those of you who are not from India, that's really the frontline, one of the frontline health workers, because you also have the ASHA workers, right? But the Anganwadi workers and the ASHA workers. Anytime anything happens, you just, the ASHA workers or the Anganwadi workers will do that, right? They're already overstretched, and I don't know, in terms of, if I had to say a dollar figure, probably they get $10 a month, or maybe less, I'm not sure. And the amount of work which is really put on their shoulders is unbelievable, in terms of their skill building, in terms of their motivation. There's so much that needs to be done. So really, Mushtaq, Bhai and Shalini, wanted to get your insights and responses to the question. Feel free to add any further perspectives, but I think it's such an important question that we really all are tackling. And we've been talking about it for years, for decades, I think. And is there something really strategic that can be done now to really make a significant shift?
Shalini?
Thank you. This actually is really at the core of all this discussion, you know, that we are talking about people in the center, we are talking about community engagement, and I think it's so important to understand that things have to be done actually in normal times, not in crisis times. So I would think that one of the key things that should happen is that during normal times, how do we proactively work towards creating and then sustaining community groups, community networks, and so on. Because communities are not going to be created overnight. And during a crisis situation, you can't really expect people to converge and then to work as a team, because this has to be, because all communities and community networks actually, you know, have a soul. They all know what has to be done and they work in unison towards a common goal. But that happens because they are, you know, they are created and they are there for a very long time. And in COVID times, we actually saw this happening quite well, because there is no counterfactual. We cannot say whether this really was the reason why in certain communities and certain places, you know, COVID was less, you know, virulent or whatever. But we do find small examples here and there. And I would just take one leaf out of our, you know, institute's work, because we have a tradition, or I should say a practice of having field action projects, you know, which is where faculty and students invest their time in working in the communities and over a long period of time. Some of the FAPs are 18, 20 years long, but they're very small, sustained, gradual work, but they actually impact policies, they make reforms, they work at the highest level, they work at national level, and they make things happen. So the community which was just close to us, the M ward, surprisingly did not see such high numbers of COVID as compared to other informal settlements. And one of the reasons was that we work in the communities with a lot of volunteers who we could just, you know, mobilize for action. We didn't have to, I mean, nobody had to spend any time in doing any kind of mobilization. We just immediately were in the community, running community kitchens, you know, distributing sanitary pads, working with video networks, with video clips, everything happening quickly. And I would say that there is some data to show that, you know, this, the prevalence was you know, lower than in many other communities. So what I would say is that, you know, if you ask me one action, I would say that, you know, invest in creating communities and then invest in training them and capacity building of those, you know, because leadership training, etc., etc. And I think we can really work, you know, down, what do you say, bottom up kind of an approach. As Dr. Malla was asking, where do we begin? And I would think that we have to begin with the community, because that will be a bottom-up approach. And it always has worked, and best practices are there in globally to show that, you know, in many, many situations this works. I don't think, I mean, I can't say it works in every situation. We do need a strong health system. We do need medicines. We do need treatment. But then, as Dr. Mushtaq said, you know, you had the ORF, the ORT, but why did it not work? Because then there was all these gender dimensions and so on, which were not being tackled, right? So I'll stop here, and maybe Dr. Chaudhary will take over. Thank you.
Well, I think the community health worker thing is very close to my heart as well. And one of the reasons I believe that Bangladesh has done well is that they have been able to train thousands of community health workers. My organization, BRAC, alone trained at some point 100,000 workers, and they were there in almost every village. So that was the experience we have. And I think the first organized community health worker program was all of you know, the barefoot doctors program in China, and after that, of course, in the Alberta, it became part of the health system thing, and there the community health worker was very much emphasized. The reason was that there were, of course, shortage of trained health workers. Also that the countries were not being able to bring the trained doctors to the village, for example. Also that the community health workers are very close to the communities, and that the community health workers, unlike the doctors, they never migrate, so they stay in the village. So these are some of the reasons why community health worker program have been flourishing. There were hundreds of experiments around the world, both in the developed world as well as in the developing world, but not many of them were successful. The success depended, in my opinion, on two things. One was that the community health workers, I mean, in most cases, they are from the poorer sections of the community, and they're women. We expect them to work voluntarily. But that's not sort of that doesn't help in sustaining their interest. So what is important is that there has to be some kind of incentive built into the community health worker program. No, not necessarily always financial incentive, but also other incentives. So that's one thing. The second thing is that they have to be linked to an existing health system, whatever faulty that system may be. These are the two minimum things that have to be ensured in order for the community health worker program to sustain and provide the services. But we have seen that the government and as well as the medical professions have been looking at the community health worker as kind of a poor option. So what is important is that the mindset has to be changed, that the community health workers are there and they can provide services which the current medical profession or the professionals are not being able to provide. In order to take these community health workers into the new sort of generation, for example, there are two things that we have to remember, I think. One is that the context has changed. So in the 70s, for example, the literacy rate was very low, and the people were very poor. I'm talking about Bangladesh. So whenever we wanted to get women to work as community health workers, it was not difficult to find them because they are there. But the situation has changed now. Many of them are actually literate, and also there are a lot of economic activities happening in the village. So the opportunity cost has gone up. So it's not easy to find a similar kind of situation as it was in the 70s. The second thing is the epidemiological transition that is happening in most countries, and that in the 70s it was more of communicable diseases that the community health workers tried to address, and they were trained for that, and they did things very well. But things are changing now. About 60% of the deaths in Bangladesh are through non-communicable diseases. So how do we really make the community health workers to be responsive to all these changes that are happening in the society? There are opportunities for the community health workers to contribute to the NCDs, for example. I mean, the aging becoming there, I mean, whether we like it or not. There will be more need for palliative care, physiotherapy, and also this morning we talked about mental health. So the community health workers can be trained to provide all these kind of things that we are sort of seeing happening now. So in order for them to be still relevant. We have to remember these changes that are happening in the broader society. Thank you.
Yeah, I completely agree with you. Only thing, Mushtaq Bhai, I would add is they need to be remunerated adequately. Like, what is the incentivization? They'll do all these things, but if you just pay them what they were paid for centuries, it's not fair. And also women, you see all these frontline jobs are being done by women, so it's also coming at a cost in terms of how they manage their families as well as all this additional work that is expected of them. Jeremy, I don't have a specific question right now, but anything you'd like to say? Otherwise, we'll open it up to the audience for questions.
No, nothing, except I'll just add the dimension of really power. I mean, the reason why so many things happen is and are so disadvantageous to the vulnerable, to the disenfranchised, is because they have no power, right? And if we look at, say, poverty, we look at, we compare the US versus many of the European countries and the average wages of workers and so on, it fundamentally boils down to voice and power. So beyond the transmission of best practices, but these are awkward issues that strike at the very core of our modern capitalist society. And I'm not sure this is the right platform to raise them, but I wouldn't underestimate the importance of the power dynamic.
Absolutely, Jeremy. Couldn't agree 100% or 110% with you on that. Also, I'm reminded with what Robert Chambers always said was, whose reality counts? And I think, for us to kind of constantly keep going back to that question is very important. I'll open it up to the audience now for questions, and as you're posing your questions, let me know who amongst the panelists you want to respond to that question. Sahil Bhai, I saw your hand go up first, and then you'll come to the gentleman in front.
Deepali, one thing that we have observed is that a lot of data is collected, but the insights and the analysis from the data is never shared back with the community, especially when you talk about vulnerable and poor communities. So even when we go to collect data, one of the things that community members ask us is what happened to the data that you have collected 6 months back? We have not heard anything about that. So how does one address this asymmetry or the data asymmetry? And then the second question is, as the global learning collaborative thinks about how to share data with the ecosystem, with governments, with policymakers, can there be thought given on the best practices and strategies to share the data back with the community as well?
Do you want to address it to any of the panelists?
So I heard Shalini say, talk about information asymmetry.
I think the question is, a very pertinent one. And my sense is why this happens is that the world over, we are so driven by quantitative research, positivistic framework, where, we are the data collectors, we are the ones who need the data, and you are the ones who have to give us, so, you ought to give us. But we don't have this sensitivity to the fact that we have taken away somebody's time, and that we must at least give back in terms of knowledge and information. Now, this is where we work within the positivistic framework. But now in the last 20 years, or I should say 25 years, things have moved, and I have to again admit, largely due to HIV research, where so much got driven by communities themselves, and then they started also talking about issues of ethics and so on. So the health ethics became a very strong component of that research. And I can say that because as a qualitative researcher, I found myself trained as a quantitative researcher, as a psychologist, very much in the positivistic framework, but slowly I started to understand that there is something beyond quantitative research, which is qualitative in nature. And then as more I worked in it, health ethics became so important, and one of the very important components of that is that disseminate, go back and inform your communities, inform your people from whom you've collected data. So I completely agree with you that part of the time we have lost it because we didn't go back to the communities. But in HIV, this is not how we did research. We completely took communities at the table. We informed them, we disseminated, we took back from them. In fact, we strengthened and we accepted communities' own, ability to do research. A lot of the communities of sex workers, of MSM, of IDUs, they did their own research and very, strong research. So I would think that, this is a very important piece of research that disseminate and go back to them. And one of the things which I just thought you asked about, how do we make sure that all this, wonderful documents that Aida talked about can be shared with policymakers. And I think they are shared, but they are not probably acted upon. I don't know if Aida will agree with that. Sometimes they are not. And one of the avenues to do that, my sense is that it should be taken to academic institutions. So, because when the students are exposed to that, and maybe they are the ones who can also pilot test a few of them and, look at those, critique them, use them in communities and so on. There's not only a wealth of data which can be used or not used, but at least a lot of training, and through them then this will get disseminated. Because I'm also very surprised that none of us said that we have heard or we have known about those documents. This is one suggestion I can give. Aida may add a few more. Thank you.
Yeah, please.
I think it's a question which doesn't have a good answer, actually, in the sense that we don't have a clue how to really bring back the research into the community from where the data were collected. But it's being tried in some other ways as well. So one of the things that we talked this morning about, the whole idea of this project, that you have research findings and then go back to the implementation, learn from there, and then as a kind of a loop that is there. So through that, it's happening. It's probably the community is benefited by that. Secondly, is that there are many research institutions which are now sort of putting more emphasis on popular writing. Normally the researchers want to publish in the Lancet, or which the common people don't have access to. But these research institutions are now pushing that along with the Lancet article, one has to publish these in easier language in the local newspapers. So it is expected that probably those in the village, they'll not probably read it, but at least some of the other people will have access to that. I wanted to also share with you one of the things that we did when I was the director of research at BRAC. We used to do all the research reports were in English, and BRAC field workers were not very good at sort of reading English that we found. So we started producing twice or thrice a year a compendium of this research in easy language as part of a journal, and we used to send it to the field offices. Apart from that, we also used to organize conferences in the field where we presented the research results. So these are some of the kind of ways that we tried, but not necessarily to the people who provided that.
Just to add just one thing, I think as Mushtaq Bhai you said, we still have a long way to go to really get to the place where we stop being extractive and share back, with the communities. But I'm saying even in terms of going back to the Anganwadi or Asha worker, like they're collecting tons and tons of data. I mean, if you see them moving around with 12 kgs of registers, where they're manually filling up everything, that goes up the chain. The analysis doesn't come down. And right now, technology has so much to offer. You get onto, if you have a Netflix account, you've entered that account once or twice. Next time when you open it, they'll search what are the movies you should be watching. Why can the Anganwadi worker or Asha worker not have that tool on their phone where the minute they open up, they fill in the data, they know that these are the 3 high-risk mothers based on all the data that they've generated over the last 1 month. I mean, it isn't difficult, but you need to have the will to really make sure that you are kind of getting, the back end and the front end pieces working so that you really analyze this data. And I think half the data probably, if you start analyzing, is not even needed. So there's so much work that needs to be done where we're collecting information which, somebody can actually link all the back end with Aadhaar, etc. And there are groups that are doing that, but very important question. In the interest of time, to the gentleman in front, you had your hand up as well.
Yes, I had a very similar question, but let me be a bit more provocative given the previous question. I want to build on what's already been asked, because I had a very similar question, but let me be a little bit more provocative and on this point, really a point about numbers, accountability, and trust. And Madam Chairperson, by the way, this is an excellent panel. Thank you very much. I really enjoyed it, and I've learned a lot, so thank you very much. But, I've been in more, we talked at the beginning about the fact that there were not enough indices, there were not enough data collected. I think there's been a number of indices being developed over the past few years. We talked about the primary health care, and there's a PHC performance index that's now been developed that countries can use. That's great. The DIA talked this morning about the national health accounts, which is a great starting point for health financing reform, financing resilience. But, I've been in more than one meeting with the minister in different countries, and I'm not talking about countries in this part of the world, but in other parts of the world, where the minister has said, thank you very much for those numbers. They're not acceptable. Please go back and change them. Please go back and change them so that they are politically acceptable. And so this is often the leadership they're facing. They have to give out a good report. And when you have decentralized systems as we have in Asia, then you depend on local leaders to pass up that information. And often local leaders face the situation that they have targets. And they have to meet those targets. And so they pass on information that allows them to meet those targets. So I think we are collecting a lot of information. The information that we have is not always given back in a way that is completely transparent, as you have just made that point as well. And I think that creates mistrust at local levels with community leaders, with community health workers, with individuals. And then, they go on their phones and they find out so many different things with different numbers, and then they kind of check out, right? They kind of check out. And so as we move into the next potential crisis, most people are saying, gee, we can't trust any of these numbers. So how do we start with some greater accountability at the top?
Yeah, and I want to add another question before I turn it over to the panelists, is that what's the incentive for a frontline worker to share the right numbers, right? Because if you are showing your children are in grade red in your growth monitoring, you ask too many questions. Your credibility is questioned. What are you doing? So, she'd rather put everybody into a green, or, for the immunization. I mean, there's a lot of, the system isn't set up where if you get rewarded because you're really sharing facts. In fact, you're penalized if you share facts. And this is something that I'm sharing that a health worker shared with me. She said, I get into more trouble. I'd love to share the numbers, but the others who are fibbing numbers, they're not asked any questions. I look bad. I really want to be doing that, but I can't do it. So there's that reality as well. Now, any brave panelist over here to answer the wonderful question that was asked?
Nobody talked about vulnerability, disability. A little mention on mental health was there. But there's a whole section of people, a whole population, and I don't want to add percentages to it, who are also in that frame and who have no access to healthcare and health systems, or very little.
Thank you, Amma. Anybody?
Well, I touched upon that to unpack vulnerability in all those dimensions. But yeah, You asking me that question or?
I think any of you can go.
I could, but Aida is, wanting to answer.
Just from tech perspective, there are emerging technologies that are being used in the region, and including not only our region but the global experience. And I would like to highlight the usage of blockchain technology, especially in aspects of addressing the human rights, transparency, where the accountability could be checked, verified through protocols. So this is maybe we can discuss tomorrow at a different session where we enable digital. Yeah, thank you.
And I want to put in Jeremy. Jeremy, are you still with us?
Yes, I am.
Jeremy, do you want to attempt answering that question?
No, please. I was not able to hear very, very clearly, so I'm just listening to the responses and trying to infer what the question was.
Okay. I think it's okay if you don't have an answer to every question. That's something for us to think about, because this is an important question. I have the gentleman here, and then
I wanted to comment. We are talking of people's health, and nobody has mentioned people are the most important resource. And we have Dr. Shalini Bharat, who is heading a sociology institution. Thank you. And we are always taught that family is a social unit. And I say family is also a health unit. And if you want to improve health of the people, you have to build capacity of the family. We talked about community health workers, and I never found a mention of a family itself. So if the family is resilient, family has resources, the people working, generating income for the family, within the family, and family takes the decision when to seek health care. And when health breaks down, yes, they come to the health system. When they are healthy, they have to maintain their health status. So my feeling is that we should include family as one of the most important determinants of health, and everyone working on health, whichever sector you are in, build the capacity of the family for sustainable improvement in health. Thank you.
Completely agree with your
Can I
comment.
answer that?
Yeah, go ahead.
One cannot disagree with you to say that family is, the important unit, is also a social determinant. But, it's a little simplistic to say, because we are assuming everybody has a family. We're assuming all families are benevolent, and all families are, it is within the family that there are many, who get neglected because they are, there are gender operates within the family, the ageism, the sexism, so, but I'm not countering your, argument that yes, family is the fulcrum. So when we say strengthen the institutions, so family is one of the most important institutions, definitely, because it is also, I should say, the front runner or among the, health providers. It's also, and so much care is feminized anyway, so we definitely have to give importance. But I think we have to be slightly careful in saying, because then it assumes, and everybody, there are so many who will feel that, oh, then who takes care of me because I'm not with the family, or I don't have a family, my family is not going to be supportive, and so on. So a little bit of careful, articulation there is needed, but definitely, no doubt, and thank you for drawing attention to that. I'm not only, somebody who has social scientist, but I have worked in a family studies unit, so I should have been mentioning that, but I'm always careful about that, because it's a very strong support system, but we have to sort of unpack it again a little more. But anyway, that's important, because there is research to show that when there is marriage, when there is family, there is a slightly better uptake of health services, because each one is sort of motivating the other, but not always. Thank you.
Thank you. Uma, do I still have 6 minutes? Or
You still have 5.
Okay, so good. So I have a last question to the panelists. So I'm really looking at actionable insights related to the most important theme of people's health, its determinants and threats that you would like to propose that have the potential to improve people's health. We could spend half a day on that, but I would just want to put you on the spot and say, which ones do you think the GLC Dr. Reddy is well placed to help address, and I'm going to give each one of you 45 seconds. Jeremy, did you hear my question? I'll start with you.
No, it's about the GLC, right?
Yes.
Which is most important.
Yes. 45 seconds.
Sorry, but Deepali, what's the most important of which aspect of the GLC?
Around people's health, or maybe Jeremy, let me come back to you. Let's see how the others who heard the question here. So, Shalini, you want to start? We'll start from this end.
"45 seconds. I think that this group, and possibly each session, should come out with the top 3 asks that this group could get behind. That could be a list of very bite-sized asks that could be communicated to the G20 Health Sherpa, all G20 Health Sherpas across the world, as an outcome of this conference on the 3-year anniversary tomorrow of the calling of COVID, and putting people at the heart of every single one of them."
I love it. That's really aspirational. Let's turn to Mushtaq Bhai.
I mean, every country has agreed to implement universal health coverage, and it is there in the SDG 3.8, I think. But countries are in different stages of implementing universal health coverage. Each country has its own unique challenges. So it will be good to really sort of think about actionable things which can be done at the country level on a short-term basis, on a medium-term and longer-term. So, for example, in Bangladesh, one of the things which need to be done immediately is the sort of addressing the out-of-pocket. Bangladesh has probably the highest out-of-pocket in the world, with 67% sort of expenses coming from individuals' pockets. So one of the, and 60% of the out-of-pocket is on drugs, on medicines. So one of the things which the government can do if they want to implement USC is to provide free medicine, which will bring the OOP, the out-of-pocket expenses, drastically down. So it's important that each country find out its own sort of low-hanging fruits, and then act on that.
Thank you. Aida, you want to add anything?
Oh, thank you. I think, Dr. Krishna, thank you. I like how you said we need to expand global to local, and our panel is confirming that. So it's the other way around, not from local to global, but the other way around. So I like this cyclic approach. So every time we go to the next level. So in my world, maybe I want to look at the health and digital components to be interoperable. So how to deal with that? Maybe your platform can show off case studies, examples. Ideally, maybe at the next level, we can make it the platform and the website, make it real-time based, where the data could be inserted instantly. Yeah, that's it.
Thank you so much. And I know there were many other hands that were up.
If you want, I can just go now. Sure. I think there is a lot of data available. It's not that there's dearth of data. So my 2 actionable points which I could suggest to GLC would be, can we sort of mine that data a little more to say, what is working and what is not working as far as on the ground kind of a thing is concerned, and if we want to bring communities along. And the second thing would be that can we also have some people work on qualitative indicators of, what works, because there's so much quantitative indicators, and I was listening to what Dr. Sohail was saying. It's very impressive, but maybe there are some qualitative indicators which tell us a little different side of a story, and perhaps if we had looked at those indicators would have told us, no, you're going wrong, you're not prepared. But everybody thought that, what we have is good enough to tell us that these are the best, health systems, but they failed. because we probably didn't take into account some of the qualitative. And I have been wondering, how to define and how to work towards that. I think GLC would be in a good position to do that. Thank you.
Thank you so much. And we didn't have enough time for all the questions that the audience had, but I think over tea break there'll be ample opportunity to carry on this conversation. Thank you so much, Dr. Reddy and Uma, and of course all the panelists for the wonderful responses and insights that you provided.
90 minutes, and you thought that would be a long session. And every 90 minutes that I have been a part of since the morning is not ending at 90 minutes. So you know how much we are bringing together and how much we are learning. One Health, learning to action and action to learning. ICT and its all its manifestations and uses. No power to the disadvantages and the voice that they don't have, and how can we bring that together? Health literacy and advocacy. Learning and tracing and training. Whose reaction and how much? Inform your communities and make sure that they become a part of who you are. And each of you have actionables for each of us to take away and bring back this entire learning journey to focus on how we can become the voice of the people and how people can become our voice. So going bottoms up. That's something that we will look forward to. I'd like to bring Stuti up here to help recognize all the work that has been done. Can I get Deepali to please do the honors? Thank you, Mushtaq bhai. Aida, thank you so much. Lois. Can I bring Dr. Srinath Reddy up, please? Because he wasn't here when we felicitated our tag members. And I'd like Deepali and Dr. Reddy to felicitate Srinath Reddy Garu. No, that's not. Sorry, why you felicitate? Sorry, we were going to Deepali, yes. That's enough. Dr. Reddy? Yeah, abdicating of your responsibilities, ma'am. And Deepali. That's right. Yes, you do need to get them. Come. Want to get a picture? Can I get my picture? Come on. All of us. Can I have everybody up?